Hello, I'm Alan Gaboski. On behalf of CME Outfitters, I'd like to welcome you and thank you for joining us today's educational program entitled All Hands, Integrating a Team Approach to Risk-Benefit Individualization of Rheumatoid Arthritis and Psoriatic Arthritis Therapy. Today's activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. Today's CME CE activity is also eligible for the American Board of Internal Medicine Maintenance of Certification credit, and there are 3 steps to complete. Actively participate in the meeting by responding to questions and asking or answering faculty questions. Complete your post-test and evaluation at the conclusion of the webcast, and be sure to fill in your ABIM ID number and date of birth on the evaluation so CME Outfitters can submit your credit to ABIM for your certification. You can also claim this activity for CME for the MIPS improvement activity of CMS, and there are several required steps to claim CME credit for the MIPS improvement activity programming. Actively participate by responding to ARS questions and or asking us, the faculty, questions. Complete the activity post-test and evaluation at the link provided, and over the next 90 days, actively work to incorporate improvements in your clinical practice from this presentation. Complete the follow-up survey from CME Outfitters in approximately 3 months, and CME Outfitters will then send you confirmation of your participation that you can then submit to CMS attesting to your completion of a CME for MIPS improvement activity. Engage with us on Twitter. Follow us on Twitter at CMEO Outfitters for upcoming CME/CE opportunities, healthcare news, and more. One last item. I want to note that we're using an enhanced platform today that allows you to save slides, take notes on slides, answer polling questions, and send us your questions. Please look at the tabs on the left of your screen and give us feedback on the program and the platform as well. As mentioned, I'm Alan Gaboski, Professor of Medicine at Weill Cornell Medicine, an attending rheumatologist and co-director of the Clinic for Inflammatory Arthritis at Hospital for Special Surgery in New York, New York. Let me first welcome my friend and colleague, Dr. Philip Meese. Phil is Director of the Rheumatology Clinical Research at the Swedish Medical Center Providence St. Joseph Healthcare System. He's clinical professor at the University of Washington School of Medicine in Seattle, Washington as well. Welcome, Philip, and thank you for joining me today.
Thanks, Alan, for having me.
Let me now move on to reviewing our learning objectives. Our first learning objective is to develop short and long-term therapeutic strategies that will account for the risk-benefit in the management of patients with rheumatoid arthritis or psoriatic arthritis. Our second objective is to integrate a multidisciplinary approach in the treatment of psoriatic arthritis. And our third learning objective is to incorporate shared decision-making into the selection of appropriate treatments for patients with rheumatoid arthritis or psoriatic arthritis. Let's start the program with a case. Let me introduce Eli. Eli is a 52-year-old Black male referred to you from his primary care physician for evaluation of joint pain believed by the PCP to be rheumatoid arthritis. The PCP has been managing him with naproxen 500 milligrams twice daily, but the PCP believes that Eli's care needs to be escalated, but he's not comfortable going any further. Your examination of his joints reveals swollen MCP joints on the left hand and wrist involvement. He reports that his toes have recently become swollen and tender to the point that wearing shoes has become quite uncomfortable. You look at the arthritis screening panel sent along with Eli's notes from his PCP, and you find that he has a positive rheumatoid factor of 24 international units per milliliter, an anti-CCP, an anti-citrullonated peptide at 18 international units per milliliter, an ESR, erythrocyte sedimentation rate at 30 millimeters per hour, an ANA that's positive, and a C-reactive protein of 8 milligrams per deciliter. The range in that lab is 0 to 5, so 8 is elevated. Now, our first question, based on the lab results and examination, do you concur with the diagnosis given Eli by his PCP? Yes, the lab results and examination indicate RA. The results seem to be pointing in the direction of RA, but are not conclusive. More information is needed before making the diagnosis, or I'm not sure. Please take a moment and make a selection. Well, let's see. About 20% of you thought the lab results and examination indicated rheumatoid arthritis. About a third say the lab results are pointing in the direction of RA, but not conclusive. 23% more information is needed. 4% I'm not sure. So 3 and 4 are really pretty much the same. You need more information. So more of you need more information than are suggesting that we've yet made a diagnosis. So let's see where we go from here. But before I say where we should go from here, what would be your next steps? Would you ask for more detail about the history, including a family history, other features such as a skin rash or problems with his eyes? Obviously, one wants to get as thorough a joint exam as possible, including other areas perhaps. Are there tests you would repeat? Would you do an ultrasound of his joints? Would you order radiographs of his joints? Would you do all of the above that I've mentioned so far? Would you start methotrexate and add that to his naproxen and have Ellie return in 4 weeks? Or again, I'm not sure. Please take a moment and make a selection. So we've gotten a bit more information and we've moved in the direction of getting some lab tests. We've moved in the direction of getting some some non-invasive studies, the ultrasound and plain x-rays. Some of you have opted for adding methotrexate at this point. Some of you are still not sure. Phil, where do we go from here?
Well, I think that it's encouraging that the audience is not jumping to conclusions because, as we'll come to discover, there's more to be learned. And that's often the case when we're evaluating a patient in a rheumatology practice. So I would want to certainly do a more careful and thorough physical examination. And part of that, and partly because I'm so used to taking care of patients with psoriatic arthritis and looking not only for involvement of lower extremity joints and entheses, so I want the patient to change into a examination gown. I'd want them to take off their shoes and socks, maybe getting them to take off their shoes and socks toward the beginning, so that their feet have aired out by the time that I get down to them to examine them. And I certainly will want to look carefully at the patient's skin. And I usually start up in the scalp and ask the patient about have they had any problems with excess, quote, dandruff. I look behind the ears because that's a really characteristic place for psoriasis patches to hide. But note what's in this patient's case. We find a little bit of psoriasis in his umbilicus and in his nasal cleft. Well, boy, if you're a patient, you're going to be wondering, who is this guy I'm coming to that's peering into my belly button and looking at my butt? And so, but that's, it's interesting that those are two places where psoriasis can hide. And also looking at the bottoms of the feet and the palms of the hand, because sometimes a patient can have a different variant from standard plaque psoriasis. And of course, we want to get more laboratory, but we already have quite a bit of laboratory. And one of the things that is confusing about this patient is he's thrown a smorgasbord of autoantibodies at us. He's got a mildly positive rheumatoid factor, CCP antibody, and ANA. I mean, where the heck do we go with that? The patient's going to say, well, gee, do I have lupus? And it looks like I've got rheumatoid arthritis. What's all this discussion about psoriatic arthritis?
Yeah, Phil, I mean, Eli is thinking, who is this guy looking at my butt? My doctor sent me to check out of rheumatoid arthritis, right?
That's right. So
you're right. I mean, this Eli has presented us with a smorgasbord, leading us to the differential diagnosis of most of the more prevalent diseases that we see, but a couple in particular. So let's talk a little bit, Phil. Tell us about the similarities and differences. Compare and contrast rheumatoid arthritis and psoriatic arthritis.
Well, a key point is that both conditions share synovitis as a key issue. And so we're going to be looking for and seeing potentially swollen and tender metacarpal joints, proximal interphalangeal joints, wrist, knees, ankles. Those are going to be shared between rheumatoid and psoriatic arthritis, and may not be able to help us distinguish given what I've just mentioned. But if we look a little bit more carefully, for example, look carefully at the distal interphalangeal joints and find sort of squishy changes of synovitis as opposed to enlargement from Heberden nodes of osteoarthritis, then that's going to be more characteristic of psoriatic arthritis than rheumatoid arthritis. We're going to probe a little bit to find out if he's got any inflammatory back pain symptoms. We're going to look carefully at the digits to see if there's swelling of a whole digit, or so-called sausage digit, because you don't see dactylitis in rheumatoid arthritis as you certainly can in psoriatic arthritis. If we move beyond the joints, then of course we've already talked about the skin, but the enthesial exam is going to be important. So palpating around the Achilles tendon and plantar fascia insertion, or around the kneecap where the ligaments insert to the patella. If we move into beyond the musculoskeletal evaluation, then of course the skin that we've already spoken about, and get to discussing about functional ability and comorbidities, many of those are going to be shared. So the patients are going to be equally discomfited and unable to do some of their normal tasks with either disease. And many of the same comorbidities are shared. For example, cardiovascular comorbidities, fibromyalgia, but a little bit more in the way of obesity and metabolic syndrome in patients with psoriatic arthritis. But I think that at this juncture, it's going to be, you're going to be saying, well, either this person has rheumatoid arthritis and some psoriasis, and that can happen, or we're going to think this person has psoriatic arthritis. And that's where some of the imaging, including ultrasound, and if we pick up enthesial abnormalities and power Doppler light up in the, for example, in the enthesial insertion sites, that's going to help us. Or if we probe a little bit more in the spine in distinguishing psoriatic arthritis.
Yeah, I think we've got a lot of overlap here, a lot of similarities, and you've already done a superb job of giving us some of the clinical characteristics of psoriatic arthritis and rheumatoid arthritis. I think we can certainly appreciate that synovitis and its resulting pain and swelling are common to both. And the problem may be that we can't really say it's more in one than the other, because it depends on the activity of it when you see the patient as to which is going on. You've commented on enthesitis, dactylitis, synovitis. A word or two about nail dystrophy, Phil. Is that common in rheumatoid arthritis?
It is not, and thanks for pointing that, Alan. It is very important to take a look at the nails, and sometimes we're frustrated because if it's a woman and she's done her fingernails and toenails with fingernail polish, then we can't really tell. But if assuming that we can see the nails, then we're either going to look for gross changes of onycholysis or other forms of nail dystrophy, or the very, very subtle changes of nail pitting. And my favorite way to really carefully look for pits is to look at the nail tangentially with some kind of light source in the background, a window or a light, and looking carefully for any sign of pitting, which can be a giveaway for nail dystrophy, which is present in something like 85% of patients with psoriatic arthritis.
Yeah, you remind me, Phil, that my patients on the East Coast may be a little bit different from yours on the West Coast. They don't get angry at me when I'm looking for skin change in the natal cleft. They get angry at me when I reach for an acetone swab to ruin their $100 manicure
Yes.
to check for nail pitting. But
Right.
It is important whether we're looking for rheumatoid arthritis or psoriatic arthritis to assess the nail for changes that you correctly described may occur. I think that Eli also poses a challenge to us because of some of the things that we've seen in his blood. And I refer to the serologic characteristics. He has a positive ANA, he has a positive CCP, he has a positive rheumatoid factor. Talk to us now about using the lab to help tease out those differences.
So you've touched down on the serologies as an important distinguishing point. And back in the days when Moll and Wright were coming up with the first classification criteria for psoriatic arthritis in the early 70s, they, as part of their classification, they said in a patient, inflammatory arthritis in a patient with psoriasis and a negative rheumatoid factor. However, we have learned that some patients with classic psoriatic arthritis may have a positive rheumatoid factor and CCP antibody. Usually they're low titer, for example, as in the case we're seeing today. But in the CASPAR study, which led to the current classification criteria for psoriatic arthritis, a rheumatoid factor was positive in 5% of the PSA patients, and 8% had positive CCP. We had a little committee that adjudicated each of these cases, and the investigator for any patient that had a positive serology had to defend why they thought this patient had psoriatic arthritis rather than rheumatoid arthritis with psoriasis. And in each case, we were convinced they had enthesitis, they had evidence of spondylitis, they had a prominent family history of psoriasis, and so on. So it can happen. C-reactive protein is noted here, and we more commonly see an elevated CRP in rheumatoid arthritis than we do in PSA. The usual statistic we use is that about 40% of patients with active PSA will have an elevated CRP. And so that is, if present and elevated, we can use it as an inflammation marker. But if it's normal, we can't rule out active inflammation. And then there are a number of other immunologic points that are made here. And I think what's the take-home message is that TNF is equally important in both diseases, and inhibition of it can yield great benefits. And then we start to diverge, and we find that the IL-17, IL-23 axis is more important in psoriatic arthritis and not so much in rheumatoid arthritis, whereas IL-6, on the other hand, is very important in rheumatoid arthritis and minimally so in psoriatic arthritis. And so beyond the TNFs and perhaps beyond the JAK inhibitors, then we get into more precision medicine, if you will, where it's important to make a distinction in Eli's case about whether he has PSA or rheumatoid arthritis.
Sure, and I think the key takeaway from this slide is that the C-reactive protein and the SED rate are non-specific markers of acute inflammation, which can be elevated or not, depending upon the disease, the stage of the disease, and what else is going on in the patient at that time. Obviously, in addition to the blood tests and some of the clues about the pathogenesis from cytokine levels, which we don't measure in clinical practice, obviously, it's important to talk about some of the imaging characteristics as well as the genetic characteristics that may give us clues as well. Phil, walk us through this, if you would.
Sure. So I would say the basic take-home message is that in rheumatoid arthritis, this is predominantly an erosive and joint space narrowing characterized disease when it comes to imaging. So we're going to see evidence of a gradual loss of bone adjacent to the joint and joint space narrowing. Whereas in psoriatic arthritis, we can see that, and sometimes it can be dramatic, typically not symmetric as compared to rheumatoid. So we might get one dramatic change in a dactylitic third digit on one hand and not so much on the other hand. But the other peculiar feature about PSA is that along with erosive changes, you can get proliferative changes. So I have x-rays of some of my patients where in one finger, they've got nearly complete dissolution of the DIP and joint, and maybe a part of the PIP joint, implying erosive changes. But then in the digit right next door to it, we'll see ankylosis, i.e. an osteoproliferative process. And right next door to that, we'll see a patient, a PIP joint with periarticular osteitis, these small little whiskery calcific changes around the joint. And so we can get in the same patient in adjacent digits osteolysis and osteoproliferation. And this can be driven by the same cytokine. For example, IL-17 can go in both directions. And in the spine, we can see osteoproliferation occurring in the form of syndesmophytes. So these are some characteristic features of radiographs. And then on ultrasound, there are some important differences, including the fact that we generally see more aggressive synovitis, deeper and more significant synovitis, a little bit less so in psoriatic arthritis.
Let me tackle the genetic question. Obviously, we've learned over the last 30 years or so about the shared epitope in rheumatoid arthritis that seems to be exclusive to it. And we've also learned that in the seronegative conditions, HLA-B27 seems to be more of a marker, probably more for axial disease and peripheral disease. Would you agree?
Yes, I would say so. B27 is positive in typically somewhere around 15-20% of patients and with PSA, as opposed to say 85 to 90% in ankylosing spondylitis or axial spondyloarthritis, but when it's present, it's going to be, you're going to be suspicious for the presence of spine disease associated with PSA.
Sure, but for a patient whom you're seeing with a typical, unquestionable peripheral psoriatic arthritis, obtaining HLA typing probably wouldn't be of particular value.
I agree. That's correct. Thanks for pointing that out.
And these are things that give us clues, but really are not in and of themselves diagnostic. People with the disease may be negative for the factor. People with the factor may be negative for the disease. So it's just some more information that we garner in order to help us make the diagnosis, but really it's not ruling it in one way or the other. Let's talk about common comorbidities in psoriatic arthritis. Phil, you've already alluded to them, and we'll come back to them in a minute as well. But among the things that we think about in psoriatic arthritis is inflammation of the eye. Certainly uveitis and iritis tend to be more common in psoriatic arthritis and rheumatoid arthritis. We see patients with associated inflammatory bowel disease in psoriatic arthritis, more so than in rheumatoid arthritis. We see an increased risk of cardiovascular disease, particularly hyperlipidemia, hypertension, insulin resistance, diabetes, and obesity. Patients with psoriatic arthritis, as you and others have published, tend to have a higher BMI than the general population, and probably distinct from rheumatoid arthritis as well. But I want to focus on the psychosocial burden for a moment, because there seems to be a higher incidence of anxiety, depression, suicidal ideation, and substance use and abuse in these patients with psoriatic arthritis as well. And I think it's important that even though that we are specialists, you and I, that we have to focus on the whole patient and their mental health burden, as well as how it's affecting their physical function when we're evaluating patients with rheumatic diseases, in particular, psoriatic arthritis.
Alan, all good points. And before leaving the slide, two things. Many of these comorbidities are genetically driven. So as hard as the patient will to try to control things like weight, blood pressure, and so forth, they're fighting an uphill battle because of genetic proclivity. So it's important to be their ally in this effort and not sort of castigate them. The other is that there's a double whammy going on here in these patients, driving some of these psychosocial issues, including this very embarrassing skin disease along with disabling musculoskeletal pain. And so I think that is why we tend to see higher rates of these even in a rheumatoid population. One that's left off of this list is fibromyalgia or central sensitization. It kind of goes hand in hand with some of these issues like depression. And in studies that have been done around the world, we have seen anywhere from 15 to 20% of patients having this concomitantly. And so sometimes when the patient has persistent pain and fatigue and sleep disturbance, it may not be the fact that we're not controlling their disease adequately, but rather that we're missing that they have a fibromyalgia component, which needs to be addressed separately than switching between immunomodulatory medications.
Yeah, and we're going to come to that in just a second, but I just want to wrap this section up with our next slide, trying to look at the differences between psoriatic arthritis and rheumatoid arthritis from 30,000 feet. There are similar clinical features, there are distinct clinical features, but because of the similar clinical features and therapeutic choices, often healthcare providers and more often payers don't differentiate between these two conditions with respect to treatment. We have agents that are indicated for both of them that we can use, and so often the specific nosology and the specific nomenclature becomes less important. But as we saw in one slide, and we'll talk about a little bit later, there have been differences in the types of therapies, the targeted therapies, as a result of key differences in the underlying pathogenesis of these diseases. Now, Phil, this is largely your work, looking at the comparative disease burden in patients with rheumatoid arthritis, psoriatic arthritis, or axial SpA, data from the two corona registries. Tell us a little bit about this and how we can incorporate this into our practices.
I think there's been sort of a historic myth that rheumatoid arthritis is the most troubling disease that we as rheumatologists treat. And the PSA and axSpA patients have been sort of a poor stepchild in terms of thinking of them as being equally impacted. But indeed, when we actually go in and take a look at a number of different factors, not only actual joint involvement or degree of pain, but also the overall assessment that patients make, their levels of fatigue, they're really very similar. And in some instances, for example, with pain, numerically even greater in AxSpA, and PSA is certainly similar to RA in terms of pain. So I think that we need to respect these conditions, the spondyloarthritides, in a very similar way as rheumatoid patients, and take it seriously and treat it aggressively, these conditions aggressively. And a part of what we've learned when we look at registries around the world is that PSA and AxSpA patients just aren't as aggressively treated as rheumatoid patients. So that needs to be corrected.
No question about that. I think psoriatic arthritis is certainly taking on much more importance in our professional societies. And indeed, we're seeing a lot of the new therapeutic efforts directed towards psoriatic arthritis for just that reason. A couple of words about this, we've already alluded to it, that we have agents that are based on some of the pathologic processes that we saw earlier, that are attempting to target them, to individualize therapy. But we also have agents that are utilizable in both conditions. We have the TNF inhibitors that can be used in both. We have JAK inhibitors, tofacitinib in particular is approved for both. We have others that are approved for rheumatoid arthritis that are studying their effect in psoriatic arthritis, and those development programs are far along. We have the T-cell activation inhibitor, abatacept, approved for both. And then we have a number of drugs that are approved for one or the other. Conventional synthetic DMARDs, more for RA than for psoriatic arthritis. The IL-17 inhibitors, the IL-12/23 inhibitors, the IL-23 inhibitors, particularly for psoriatic arthritis. IL-6 inhibitors, more for RA. CD20 inhibitors, more for RA. A PDE4 inhibitor with a novel oral delivery for psoriatic arthritis. And then, of course, I've mentioned the other JAK inhibitors approved for RA with psoriatic arthritis development programs as well. Phil, any comments from you on this slide?
Alan, you covered it well. I think this reflects the fact that we have, to use a word again, a growing smorgasbord of options for treatment, so that if we are able to get a patient into remission or low disease activity, say with a TNF inhibitor as the first agent out of the chute after methotrexate, we now increasingly can turn to patients and say, if you begin to lose benefit, don't worry too much, because we've got lots of other options to try. And it's often the case that we are able to maintain that state of low disease activity just by having multiple effective options.
Yeah, and I think that takes us to our next point, which is the pathogenesis of pain. As much as we focus on inflammation, patients focus on pain. And as we better understand the pathogenesis of pain, we can better target our therapies. Phil, what are we learning about the nociceptive pathways that can inform our treatment decisions?
So usually we have had this sort of reductionist idea about pain, that the sort of Descartes image of a human passing their finger over a flame and having a signal going from that right to the brain, and that's all pain is. But in fact, we're now learning that the neurophysiology of pain is quite complex. There are, of course, peripheral nociceptors that are telling us that inflammation or trauma or passing our finger over flame is painful, and that signal is going through the dorsal horn of the spinal cord and up to the brain. But it turns out that there are also many, many modifying influences along the way. And what often happens in states of chronic inflammation or chronic pain is that there is, with certain individuals that are genetically predisposed to develop increased central sensitization, as we call it, there is an uptick of genetic regulation of pain signaling. So you get an increased expression of central nociceptors. And in certain individuals that are more sensitive, if you will, than others, this becomes a chronic, persistent upregulation of nociceptive input and diminishment of so-called inhibitory downstream effects. And so you get a amped up pain process. And so we're learning that certain drugs may have more than one role. They can diminish inflammation in the periphery by reducing cellular activation of immune cells, reducing cytokine activation, but they can also potentially have a role in dampening down some of this centrally upregulated nociception. And some of the first signals about that came from looking at the data with JAK inhibitors, where typically we would see reduction in pain reported by patients as early as 1 week after initiation of these medications, long before inflammation was fully controlled. And so we now know that there's going to be more than just reduction of inflammation that we're shooting for. We're beginning to see that data with the IL-17 inhibitors now as well. And so it's just to say we're going to be, I think, in the future having various complex ways of evaluating this and manipulating this to better control pain.
No question that pain and its effect on health-related quality of life is probably the most important thing to the patient. We're focusing on the notion that inflammation causes pain, but we are learning that even when, as you pointed out, even when the inflammation is well controlled, the pain may persist because of effects on other pathways. Time doesn't let us go into all of those. We've just highlighted a few, such as the randomized controlled trials of tofacitinib that helped us dissect some of the pain mechanisms as well. Maybe if we drill down a little bit in the next slide, Phil, you can tell us a little bit more about this concept of pain reduction as distinct from inflammation reduction in these trials.
So what is being shown here is the improvement in pain with CSD MARDs versus TNF inadequate responding patients treated with tofacitinib, and showing the rapidity with which pain improves and pain improvement is maintained in both rheumatoid as well as psoriatic arthritis patients.
Great. And I think that this is a key point to leave with our audience, that pain may persist even beyond the control of inflammation. And it's important to keep that in mind as we communicate with our patients. I think before we go on to our next learning objective, I'd just like to show one more slide which highlights the other JAK inhibitor in upadacitinib for psoriatic arthritis refractory to biologics, which again makes the point that control of a JAK-STAT pathway may prove to be an important pathway in modifying the effects of the mediators of inflammation in psoriatic arthritis, just as it is in rheumatoid arthritis as well. This slide shows the differences in 2 doses of upadacitinib versus placebo in control of psoriatic arthritis and patients achieving their ACR 20 over time with this agent as well. So I think, Phil, we've shown that rheumatoid arthritis and psoriatic arthritis have similar features, and distinguishing features as well. And with JAKs, we can treat both. But as we move into other therapies, we do see differences. But let's move on to our second learning objective, which is the multidisciplinary approach in the treatment of our patients with psoriatic arthritis. Certainly what we have learned is that psoriatic arthritis may be seen in up to 30% of patients with psoriatic arthritis, and that psoriatic arthritis may precede, occur concurrently, or occur after the development of psoriasis. And so it's important to begin to conceptualize where psoriatic arthritis begins. And I think it was for that reason, a number of slides ago, when we were first talking about Eli, that you pointed out the importance of examining the skin carefully in a patient presenting with joint disease, whether they're seropositive or seronegative, because data suggests that the majority of patients present with skin psoriasis compared to those patients who present with joint pain. Nevertheless, we have to be alert to the fact that the skin lesions can occur after the presentation with joint pain, and we have to look at the skin and the nails in our patients in every visit, particularly when we're concerned about making a diagnosis in patients who have a confusing laboratory picture. And I think it's also important for that reason to be aware of the need for a multidisciplinary approach for the management of all of our patients, particularly those with psoriatic arthritis. We have a dermatologist that may be involved. Very often, the patient is being referred to us by the dermatologist, but very often we have to refer a patient to the dermatologist once we pick up the skin lesion. The general practitioner is going to help us with management of comorbidities. The psychologist may be involved in management of some of the mental and emotional problems that you've appropriately outlined for us earlier. And let's not forget other specialists like the pharmacist, who may be particularly important to us in helping our patients get some of these medications that are often available through specialty pharmacies. So I think those kinds of things are important in trying to define who, not just who owns the patient, but who is best in a position to manage what's going on with the patient at that particular point in time. I think there is a disconnect sometimes between, and I don't mean to use it as a pun, but that is the title of the study, between the dermatologist, the rheumatologist, and the patient in terms of what's important. Phil, a couple of words from you about the results in this study.
So I was intrigued to find some of the ones that were very similar, but also the ones that were most different. So for example, it seems like pain is equally regarded by patients as well as the physician, both types of physicians, derms and rheums that are taking care of them. But let's go over to the top of the right-hand bar graph. Painful skin. Do you think of painful skin, Alan, in psoriasis patients? I don't. But patients do. And that's obvious here as compared to physicians. Or there's another one here, itching, where the itching of psoriasis drives people mad. Look at the rheumatologist. It barely registers on the rheumatologist thinking process about itch. Dermatologists are a little bit more sensitive to it. Fatigue, look at where that is with the patients compared to physicians. So I think this is a very useful article and a bar graph, or if you want to teach us that there are certain things. I think it's really good to every once in a while slow down, stop, pause, and turn to the patient and say, what's on your mind? What are the biggest issues that are facing you and that most bug you about your particular disease? Even if we can't do something specifically about it, like fix the itch other than treating the psoriasis overall, I think patients really want to tell us about things, and it's good to hear. What are your thoughts, Alan, on that point?
Oh, absolutely. I think this study by our colleague Elaine Husney with a superb dermatologist, Dr. Anthony Fernandez at Cleveland Clinic, points out that our patients aren't always telling us what's on their mind and what's important to them. And we're not always focusing on it because we're concerned with what's important to us. Yet it's what the patient wants that will determine whether they're satisfied with their care or not satisfied with their care. And I think communication between physician and patient is critical, not just to alleviating symptoms, but to the outcome of the disease as well. The more we talk to our patients, the better understanding we have of what's important to them, and the more we can focus our therapies accordingly. Phil, I'm sure you've had situations where the joint pain is more important than the skin, and as well as situations where the skin is more important than the joint pain. And so what the patient is willing to put up with may often be determinative of what they want done to them more than what we want to do to them. And we'll talk more about that in the next segment, perhaps. But let's move on from disconnect, and before we finish this objective, and just point out that the clinical domains of psoriatic arthritis are multiple. We've alluded to the importance of the nail, the importance of the fingers and toes. Phil has particularly alluded to the enthesitis that may occur. We've discussed the difference between the axial and the peripheral forms of a disease. And Phil has nicely highlighted for us that in psoriatic arthritis, the skin disease is of critical importance as well. Patients may have an impaired quality of life because they're often embarrassed to go out in public, shedding as they are part of the largest organ of the body every time they make a movement. So I think in our next slide, we'll bring this to a conclusion, Phil, but I really want to get your important input here about the differentiation of the two major forms of psoriatic arthritis, namely the axial disease from the peripheral disease, and then differentiating axial psoriatic arthritis from idiopathic axial disease and the axial spondyloarthropathies.
We often find that the axial disease of PSA occurs later than the inception of the disease. So a person may present initially with peripheral arthritis, dactylitis, enthesitis, and so forth. And then as the disease evolves, more and more patients will start to show evidence of spondylitis. So it's about 20 to 30% in the initial phase of the disease, and it can be up to 70% of patients once the disease is in full bloom. But it's different, and we're learning, than classic ankylosing spondylitis. For one thing, B27 is only expressed in 20 to 30% of those with axial PSA, 85 to 90% with AS. Patients with axial PSA may not have sacroiliitis at all. About a quarter of them don't. And if it's present, it may be asymmetric. That is, one side is very involved and the other side is not. And we've learned that that particular characteristic is associated with HLA-B8 and not HLA-B27. The patient may present only with cervical or a little bit of lumbar disease, no sacroiliac disease, whereas with ankylosing spondylitis, it's the other way around. More women are involved in the axial PSA. They tend to have more features of peripheral enthesitis and arthritis. And we're now beginning to learn, and I think we're going to touch upon this later, that there might be differences in treatment. Whereas we've learned that IL-23 inhibitors don't work in ankylosing spondylitis, according to a couple of studies. There have been some interesting studies that have suggested that maybe in axial PSA, the IL-23s will work.
Well, let me specifically stop you there, Phil, and ask you whether the presence of axial disease is going to impact treatment choice.
Well, of course. So I think the key point is that in numerous studies, we've found that the conventional synthetic DMARDs like methotrexate and sulfasalazine just don't work well in the spine manifestations of axial spondyloarthritis or axial PSA for that matter. So what we end up doing, if the patient has significant back pain as part of their presentation, we'll leapfrog over the conventional synthetic DMARDs and go right to a biologic, such as a TNF inhibitor or an IL-17 inhibitor, which have shown effectiveness in the axial spine. And stay tuned about some of the IL-23 inhibitors. But also, we're now getting some really encouraging data from the JAK inhibitor class of medications. So here's a perfect example of that. Thank you. This is the most recently presented data on tofacitinib showing ASAS 20 and 40 responses at week 16. So, which are highly significant and teaching us that the JAK inhibitors can work well in axial disease as well. Here we're seeing climbing treatment response and separation as early as week 2 from placebo with the tofacitinib data. And here we're showing the data that I alluded to earlier about the IL-23. So there was a trial with one of the IL-23 inhibitors, risankizumab, a pilot study in phase 2 ankylosing spondylitis that didn't show any discrimination from placebo. And there was also an ustekinumab or IL-12/23 inhibitor trial that failed to show any discrimination between placebo and treatment. But here we have a subset of patients in the pivotal phase 3 trials for guselkumab, one of the other P19 IL-23 inhibitors. And in this particular subset, they identified patients that had elevated spine symptoms and they had an evidence of sacroiliac abnormalities on X-ray that was read locally at the investigative site. And in these patients, there was a significant improvement when treated with guselkumab in their symptoms. So here we have ASDAS. It's a measure that's used in ankylosing spondylitis trials. Here we're showing achievement of inactive disease, remission in 20% of the patients. And then we're showing major improvement and clinically important improvement. This is the 52-week data. So back at the 24-week data, we had significant discrimination from placebo. And then here in the gray bars, we're showing placebo catching up at week 52. So it appears that there is something going on here where IL-23s are benefiting the axial manifestations of PSA.
Well, thank you, Phil, for that great discussion. Let's move on to our final learning objective, which is incorporating shared decision-making into the selection of appropriate treatments for our patients with RA and psoriatic arthritis. I think that one of the things that has occurred in the last year in great incidence and is here to stay is telehealth. And we have to be able to integrate telehealth into disease monitoring. Now, obviously, it has its pros and cons. It makes it easier for the patient to interact with us, but remote telehealth visits limit our ability to conduct a complete joint exam to assess disease activity. And so there are other strategies that we need to look at, such as educating patients in doing their own joint counts, educating patients to report to us their own tender and swollen joint count findings. That may mean for our traditional utilization of disease activity measures in clinical practice. We've also learned, and we've known for quite some time, that patient characteristics such as obesity, male gender, and severe stiffness of the joint may predict discrepancies in how the patient and the practitioner are going to evaluate the affected joint, both in the telehealth evaluation and in the in-person evaluation. Phil, any tips for us about successful telehealth visits that you can share with the audience?
So we've really embraced this, and part of the reason it's been so successful and appreciated by patients is that we live in a part of the country unlike you, Alan, where everybody's crowded into a small island. We here in the Northwest, people are spread out all over the place. So we have patients that are in Alaska and Montana, and so that even in different states that come to visit us in Seattle. And the ease and quality of telehealth care has improved so rapidly over the past months that we are the patients are really appreciating it. We can get a lot done. We can really tell in a very intimate way with the patient right across the screen from us on the other side about levels of pain, about how they're functioning, and we can even do some skin exam through the visual and get a feeling for grip and dactylitis. So you can actually do quite a bit in the way of evaluation. And so we've seen new patients successfully, especially if they have some background records or laboratory or imaging that we can access through the electronic record. Although I must admit that new patients are best seen in person if possible. But then obviously return visit patients, it's pretty straightforward. And if they're flaring, then we can manage that appropriately. Otherwise, just check in to see how they're doing, answer questions about their risk for exposure, or risk for acquiring COVID if they happen to be exposed, all those sorts of questions that are on patients' mind, and really deal with them emotionally. I also have found that it gets me out of trouble sometimes. For example, last night I discovered when I looked on the record that my receptionist had failed to block me out completely for this CME event today. And so I had a few patients that were fortunately virtual visits. And so all I had to do was just say, let's shift it to a later time in the day or into the evening. So it has created a degree of flexibility that I'm really appreciating. So I think I'm hoping that when the pandemic has settled down and we're able to move about more freely and come in for visits, that still we'll be able to make it easier for patients overall if we can continue on with at least some of the visits being telehealth.
Yeah, and Phil, you've discussed or at least alluded to the concept of benefits and risks, which is something that's important whether we're seeing the patient in terms of telehealth or whether we're seeing the patient in real life. We always have to be reevaluating our assessment in terms of drug-related factors, patient-related factors, all of which impinge on the treatment decision. We've talked about comorbidities, we've talked about risk tolerance, but there are so many other things that go into effective communication, which is what we're really trying to achieve. I think in the last couple of minutes, I'd just like to share some of the principles of shared decision-making, which you've already touched upon, which is the supportive environment for open discussion, which leads to things like clarifying the timeline, identification of decision options, checking the patient's understanding of everything involved in options. You know, we shouldn't assume that merely because the patient is nodding when we're speaking, that they understand us. They're hearing noise. We're making noise, but that may not translate into understanding. And all of the need for understanding is critical to achieving an optimal outcome. We need to be aware of the patient's value system and the patient's individual situation, and so that we can help the patient make decisions about options and outcomes most relevant to them. We need to be able to effectively communicate what we think is going to happen as a function of therapy, offering the patient advice as they need it, and then supporting the patient in the selection of their option. This is a very, very, very quick summary of the principles of shared decision-making, which I hope our listeners will take away. I've worked with CME outfitters in putting together a patient whiteboard animation, an easy-to-understand video designed to educate patients about their disease and treatment. And I'd just like to take a minute to show it now, an example of a resource that we can make available to our patients.
Psoriatic arthritis and rheumatoid arthritis are systemic diseases primarily affecting joints that can cause irreversible joint damage. Joint pain and loss of physical function can lead to disability and impact daily activity. Psoriatic arthritis and rheumatoid arthritis are different. Psoriatic arthritis is an inflammatory arthritis often seen in patients with the skin disease psoriasis. To determine if you have psoriatic arthritis or rheumatoid arthritis, your doctor will conduct a thorough physical exam of your joints and your skin, run laboratory tests, take x-rays to assess joints for damage. Telehealth visits are also becoming more common and are not that different from face-to-face visits with your doctor. There are a number of things that you can do to prepare if you choose a telehealth visit. Select a comfortable and quiet space for your visit. Be prepared to stand, sit, or move around so the doctor can see how you and your joints move during an exam. Share other chronic conditions that you may have with your doctor. Have a list of any other medications you are taking ready. Make a list of questions to address all of your concerns during the telehealth visit. It's hard to remember everything. Talking to your doctor and getting an early diagnosis is very important. The good news is there are several drugs that can stop the damage to your joints, but early treatment is important. Doctors use a treat-to-target approach when selecting medication to prescribe. The goal is to set a target of remission or low disease activity. At each visit, your doctor will measure how well the medication is working to meet that target. Medications may be taken as a pill, delivered by an injection, or administered by going to an infusion center. After starting a medication, be sure to tell your doctor if anything unusual has happened to you while you are taking it, such as rash, infection, stomach pain, or anything else that is of concern to you. Remember, it is important to talk with your doctor about how the disease is impacting your quality of life and your goals for treatment. Be an active participant in your care, including sharing your preferences with your care team. For more information about psoriatic arthritis and rheumatoid arthritis, visit www.cmeoutfitters.com/rheumatology digital hub.
Well, Phil, we've had a great discussion today, and I want to just summarize it briefly for our audience. And let me tell the audience, believe it or not, I have been working in to our discussion answering some of the questions that you've been putting up on the screen. And I'll get to one of the more frequent ones in just a second with Phil. But by way of summary, you need to look beyond the surface of a patient presenting with joint pain to arrive at the correct diagnosis. Eli was a diagnostic puzzle at first, but as we gained more information, we were able to tease out the similarities and differences to other conditions that allowed us to hone in on a specific diagnosis and treatment for him. While many of the therapies for both psoriatic arthritis and RA are the same, there are differences among them as well. So we really do need to individualize care, and we really do need to coordinate care between the rheumatology service, the dermatology service, the primary care physician, the pharmacist, psychologists where appropriate, and other practitioners for the optimal care of patients with all inflammatory diseases. And engage patients in treatment decision-making, engage patients in shared decision-making, and empower them to be active participants in their care. Phil, we've received a number of questions today, and please keep submitting them. We'll try and get to them as best as we can. But there is one that's come up again and again, and I want to get to that before we close, and that's, Phil, in this era of the COVID pandemic, how do you modify therapies? How do you modulate therapies? And particularly with vaccines that are now being available to our patients, what is the timing of therapies in that context?
Okay.
You got 30 seconds.
You've asked a number of questions there, Alan, and some of them we don't have the answers to, but I'll just tell you some of what we do in our practice. So in general, we haven't suggested that anybody change their treatment regimen when it comes to biologic therapies And so whether it's a TNF inhibitor, an IL-17, et cetera, both in relation to risk for viral infection, as well as the getting the vaccine, we've been advising them to keep going with them. Part of this comes from an old study that I was involved in when we did the first etanercept and psoriatic arthritis study way back in early 2000s. We embedded a vaccine trial within it as a sub-study. And interestingly, in that sub-study, the TNF inhibitor that we were studying did not negatively impact development of antibodies to the flu vaccine or pneumococcal vaccine. Admittedly, these are different molecular platforms than the current COVID vaccines, but I think that was a useful lesson for vaccination in general with the TNF inhibitors. Interestingly, in that study, the only factors that led to a reduction of antibody response was use of methotrexate, age over 65, or the presence of diabetes. So I don't know what to say about methotrexate. One might think about skipping a dose or two, weekly dose or two, around the time that you're getting a vaccination. And with the B-cell ablator rituximab, we've been suggesting that patients sort of time their rituximab, if possible, such that they have a minimal amount of it on board at the time of their vaccinations. But these are just pulling things out of the air. We don't have really good guidance on them. And in general, my advice is to stay with what you're doing. Alan, over to you.
Completely agree. I mean, don't confuse me with facts after I've already made up my mind. And to the extent that what we're doing is based on what is working for us as we're doing it, we're going to keep doing it until we get some objective data in this area. And I think that's all we can say at this point in time, that we don't have answers, but we're trying to come up with them. Sometimes it's not as important to answer the question as it is to question the answers. And that's the stage that we're in right now. So I want to thank our audience. I want to tell you that many of the questions you've asked have been answered in our discussion. Some of the others can be answered if you refer to the Rheumatology Education Hub, which I'll give you a link for in just a moment. I want to remind you that to receive CME or CE credit for today's program, please complete the post-test on your screen and then click on the Request Credit tab to complete the evaluation and print or download your certificate. If you'd like to claim the activity as a CME for MIPS improvement activity, follow the steps that will be defined for you on the next slide as it comes up. And again, I want to thank you for participating. Phil, I want to thank you for taking some time out of your busy day. I know you've been working 3 screens simultaneously that we haven't seen, and for your telehealth visit. And again, I want to encourage our colleagues to look at the Education Hub, to take a look at that link for dealing with some of the resources that we've alluded to, as well as some of the resources that you've asked about, the ASAS tool that Phil alluded to, questions about incidence and prevalence of psoriatic arthritis and so on. And I really do want to thank you for taking this hour out. Hopefully it's been educational. Hopefully it's been enjoyable. Thank you very much.